begin our day with Omkars. I request all of you to please close your eyes and with your hands at your heart center, please take the deep inhalations and exhalations. That is deep breaths. With every exhalation, keep all your thoughts, all your worries, all your stress, and all your work outside this hall. And be in present. Take a deep inhalation. Inhale. Inhale. Open your eyes with the smiles on your face. Hello, good morning and namaskar. I, Dr. D'Pankar, as Secretary Jabalpur Obs-Gynaec Society, welcome you all to our annual conference, FetusCon. As you all know, 31st October is celebrated as Fetus Day, and this concept to the world was given by Jabalpur Obs-Gynaec Society under the leadership of Dr.D'Pankar Banerji sir. The motto and the aim was to keep the well-being of unborn child. Around this day, we celebrate a conference called FetusCon, and it is celebrated since 2010. This is 14th year we are celebrating this conference, and Sorry. It is my bad. It is 15th year we are celebrating this conference, and it invites all the delegates and speakers from all over the world and all over the country to discuss the advances in fetal medicine. Today also we have eminent speakers from all over the country who are going to discuss the fetal medicine, and I am very sure that this will be an academic feast for us. I'll like to thank Dr. D'Pankar sir and Dr. Madhuri Patel madam and Dr. Sita madam, who has collaborated with us and made it a national conference with the Committee of Fetal Medicine of India. Now I'll give the mic to Dr. D'Pankar sir to proceed to give some overview about FetusCon, and then we'll start with our sessions.
Thank you very much, Jigyasa, for this introduction, and it is my great privilege to have company like eminent doctors from my state, and I especially thank Dr. Vivek that he has taken this pains, that he started at 7 a.m. yesterday, reached 7 p.m. and then joined us, and it is really great privilege, Vivek, that you are with us. And we are all very much fond of your knowledge and your teaching style. And I assure my gathering and my fellows that this will be a very good bouquet, very nice with knowledge, along with Dr. Vivek, Dr. Abhishek, Dr. Devashish. And Smita is not coming because she had undergone lumbar discectomy and she is on bed at present, but she is all right, but she cannot move. So we have changed little bit and we have replaced her lecture with, in debate, Alkesh with us. Alkesh will be with, and in a very short notice, I asked my fellow Dr. Ashita Dubey to make few slides with NIPT. And in the afternoon session, there will be a talk by a very good eminent speaker from Medical College, Pediatric Department, Dr. Shweta Pathak, and she will be talking on cord blood stem cell transplant current scenario. With this overview, can I start? Chairperson ko bula lo.
I'd like to invite the chairpersons of session 1, Dr. Bharti Sahu Madam, Dr. Shilpa Shomshekhar Madam, Dr. Gunjan Goswami Madam, and Dr. Sharda Mishra Madam to please come forward and take over the proceedings.
It's my privilege, really, to introduce Dr. D'Pankar. He is MBBS MS OBGY from Jabalpur Medical College.
Madam, just skip it.
But why you are skipping my privilege?
Because we are all most informal people, and everybody is seeing that.
On the request of D'Pankar, but D'Pankar, you are on the Google. When we search the FetusCon, it is always comes that D'Pankar is the initiation of the FetusCon, and so D'Pankar, now start your session, please.
Thank you very much, madam, for your blessings, and really thankful to you. And our session should have been started at 9:30. We are 20 minutes late, so I will ask my speakers to maintain their session so that we can finish it. We have Dr. Vivek agreed to do a mid-trimester scan live with Doppler at the end of the session, so we will try to have that advantage also from the experts. So what should be the way how we should do a mid-trimester scan. With this outset, I start my lecture, and this is a very short lecture that we done prenatal invasive procedure. What happens? Why we do prenatal invasive procedure? This is increased risk of aneuploidy. There are various indications. I am willfully not doing slideshow because I want to write something on the plate, so I will not get the draw option over there. So why we do? Sometimes most of the time we get this, that you did a first trimester combined screen and there is a high risk. So you need a diagnostic test. Abnormal ultrasound findings, you need a diagnostic test. There is abnormal obstetric history, you need a diagnostic test. There is a family history, there is a patient anxiety, you need a diagnostic test. So the most common diagnostic test is amniocentesis for confirmation of the diagnosis. For genetic disorders, like increased risk of known genetic disorders, we do chorion villus sampling, because it is done as early as possible so that the couple can take a decision to continue or not. Or patient is suffering from some carrier status, like most common in our area is thalassemia and sickle cell, or any other hereditary disorder which is autosomal recessive, and they are carriers, although they are okay with that carrier status, but they can create 25% chance that the baby might be affected. For that we need a diagnostic test. That diagnostic test, if it is not possible CVS, then we do amniocentesis. Now another thing is, if we expect that mother is suffering from some infectious disease, like in torch infection, you suspect that there might be, then you have to do a fetal infection confirmation. And I'm not going into that, that is a separate issue, but sometimes we need some invasive test for confirmation of the fetal infection, like late amniocentesis. So what we do with the invasive test? In invasive test, we take the cell and this cell contains a nucleus. This nucleus contains 2 DNA threads. One is coming from my father and one is coming from my mother. When I take this out of the cell, these are like, you make the thread like this. So my paternal thread will be like this, and my maternal thread will be like this. This is a DNA thread which of length about 2 meters, which is packed into the nucleus. When nature does cell division, you cannot make a copy of the whole thread, so you make the pieces of the thread. And then these pieces are being cut into short pieces. These pieces are of 22 pieces from my father plus 1, that is 23, and 22 pieces from my mother plus 1. So when my cell divides, there are 46 pieces, 23 from my one parent, 23 from my other parent, and then they make their copies. When I make these DNA threads into pieces, these pieces are called chromosomes. These pieces are of a different length, and when we do an arrangement according to their length, this arrangement is called karyotype. So if I do an invasive test and the indication was high risk for Down syndrome, that means that the 21st number of the piece is extra from either from my mother or from my father, mostly from mother. So when I do a confirmatory test, this test has to be done either by karyotype, but it takes a longer time. Then I should have something which is very fast. At least make the result as early as possible so that the couple can take a decision. Down syndromes are not bad people. They are good, but it is difficult to sustain with them. Otherwise, we are not here to say that this is a disease. It is an affected baby. It is up to the couple what they want to do. Suppose I do, or Devashish does, or Vivek does a scan, or Alkesh does a scan, and find that at the time of first trimester scan, at the time of 12-week anti-scan, or with anatomy, there is a problem. And you have a suspicion that there might be some problem. So that becomes another indication for confirmation. So I did an invasive test, I got the DNA, and this DNA will be used for confirmation of the diagnosis. Now, there are people who are carrying 23 pieces from the mother, those babies, 23 pieces from both the parents and 46 pieces. But when either of the parent is having this thread or this thread, I am not making at present the pieces, but in the thread there is some mistake in the writing. So there is some mistake in the writing. If it is on autosome, not in sex chromosome, then it is an autosomal disorder. If one parent is having a wrong writing, but the person is okay, that means he is not affected, so that means this problem is autosomal recessive. Now, if both the partners are carrying the same thing in their same place, then they might combine and come into the fetus, and fetus might be affected. So my concern is they are asking me that they are both are carriers, whether fetus is affected or not. This happens the origin of fetus day. That day there was a lady came to my chamber with a baby affected by beta thalassemia major, all frontal bossing and very not a good shape that baby was, that 3-year child. And she was pregnant again. And she was asking me whether mera second baby will be like this. That is a very pertinent question that you have to give an answer. So I have to know what is happening with the previous baby which is living. No, this is a thalassemia. It is not the thalassemia. You have to know what type of thalassemia. Then only you know where is the wrong writing written in beta globin gene. Then I have to see the whole gene. I have to read whole the gene. where the wrong is written so that the beta globin protein is not being formed. After identification, then I do an invasive test and identify the type of wrong writing, which is called mutation in the fetus. So this is another indication. So when I do this, so I have to do both the parents, because one is normal, one is abnormal. So we do a trio test. That's husband, wife, and the baby. So levels of mistake might be in numerical or structural in chromosomes. Another point is this pieces are okay. If you count them, there are 23 from this side, 23 from that side. But there are some missing point in this area in the chromosome which is not visible by microscope. If there are few genes over there and they are missing, I delete them. Then this part of the chromosome which is from one parent and this is another parent and this is having the same, and this part is okay, this part is missing. That means there is a difference in the copy of this area. If this happens, this is called submicroscopic copy number variation. Why it is important? Because it is more common than Down syndrome. And sometimes it is as affected as Down syndrome. So there is another thing which is submicroscopic, that is COP. If that part contains few important genes, the baby is going to be affected. Some problem. I am not going into that detail. Now, if it is a wrong right or abnormal code or mutation within the gene, you cannot see it under microscope. You need to have a sequencing. You have to read whole the gene from one end to another end. And if you find something abnormal, this is called mutation. So these are the different type of mutations. If it is a gene and this part is one part, second part, third part, they make mRNA and make the protein. So these parts are called exons. That means within the gene, these are very important. If it is within this part, not so much important. This is called intron. So within intron, most of the time not affected. Within exon, very bad. But within now this gene has been to be regulated by somebody else. If he is abnormal, then there will be a problem. Make it understand that it is not so easy. Just doing a genetic analysis, doing a mutation is not enough. Sometimes somebody else is doing something else. So it is very puzzling. But when it is decided that the gene is creating this problem, then we go that this is the problem which creates the problem. So we identify and then we do the diagnosis and tell the parents, this is the problem. Now we are all obstetricians, we have to give an answer. We just can't say, please correlate clinically. That is the main thing we have to know. So these are either very pathogenic, likely pathogenic, maybe bad. I don't know whether it is bad or not, that is VOUS. It looks good, likely benign. It is okay, benign. This is the way we express. But definitely sometimes genetic lab give this type of report, you get confused कि करना क्या है इसके बाद. So these are all structural, numerical, these are chromosome numbers we identify. Why these are important? Because baby takes birth with these chromosomal defects. So we are concerned about Down syndrome, Edwards syndrome, Patau syndrome and sex chromosome aneuploidy. So these are all different flow charts and these are all chromosomal disorders. And how we test for these genetic disorders? Either you do a full karyotype or you identify 5 chromosome, take representative sample and make a dye, make a probe that it attaches to that specific chromosomal part. So we can make fluorescent labeled probe, when it gets attached, it emits a fluorescence. So 21 will have 2 fluorescence, 18 will have 2 fluorescence, 13 will have 2 fluorescence. If we go with the X1, if it is female, I am not going to disclose the sex, then 2X or 1X and 1Y. So if I do this within 48 hours, at least I can say whether 21 chromosome, if it is extra, then I can say it is trisomy 21. So it is called fluorescent in situ hybridization. But it is a subjective thing, sometimes create problem. So what we do nowadays, we do qFPCR, that is quantitative fluorescent polymerase chain reaction. I am not going into that detail, but it is a molecular test in place of fish for 5 chromosomes, which gives results quite early. These are all microarray to understand the within the chromosome submicroscopic analysis. How we do, not going into that detail, but lab does nowadays. That is single nucleotide polymorphism, this SNP microarray. This is comparison of karyotype, microarray, SNP microarray, how it gives you advantage. You see the karyotype, you cannot see area of homozygosity, consanguinity, CNVs, but with SNP microarray you can see lot of things. But the problem with these tests is that you cannot see the balance translocation. Sometimes balance translocation misses some gene. This is the comparison of array CGH, and I am not going into that detail. And use of array in prenatal diagnosis, the committee opinion, these are very important statements. Fetus with more than one major structural anomaly, go for it. Structurally normal fetus undergoing invasive testing, anytime I do an amniocentesis or CVS, not only qFPCR karyotype, but with microarray to submicroscopic deletion and duplication. If there is intrauterine fetal death, do not restrict to, very important statement, do not restrict to advanced maternal age. Any mother can have problem. And especially some microscopic deletion and duplication. Down syndrome might be more in more age, but CNVs are common throughout the pregnancy, if any age, and they are more common. So the fetus with USG detectable anomaly, if you do microarray, submicroscopic, the incidence is 6 to 13% for pathogenic. That means they create disease. These are not Down syndrome, but they are disease creating problems. You have to find it. When USG anomaly, but in indication like advanced maternal age, positive screen, anxiety, the pathogenic incidence is 1 to 2%. That means Down syndrome is 400 to 700 in population, but CNVs may create problem is 1 out of 100. That means look the jungle in a whole. Don't search for the tigers alone. Look for the cheetah and tendua also, because they can attack you. So these are the molecular tests, and I am not going into this detail. And this is the again exon, intron, and this exon problems are when you collect all the exons and analyze them. This is called exome sequencing. Nowadays, clinical exome sequencing and whole exome sequencing is a very common test to finding the reason. So these are the molecular tests. You can go for the whole genome sequencing also. We have started with the whole genome sequencing facility in our place, and thanks a lot for patient listening.
Thank you very much for this wonderful deliberation and expert presentation. This molecular level can be only done by you, sir. And this is how amniocentesis and chorionic villus biopsy studies can detect the chromosomal and the genetic abnormalities. And to have a better outcome, we need to have these tests. Thank you very much, sir. Anybody else would like to?
Test to detect copy number variation. Second is turnover time for each test.
And third is, what is the difference between clinical and whole exome sequencing?
Madam, to request you, we will have this discussion because all the three questions are very broad, big questions. But the thing is, your first question was this method of copy number variation, how to identify. Nowadays, single nucleotide polymorphism microarray is the way. The previous days there was big chunk, we are like big chunk means long stretch. उसके भीतर का कुछ प्रॉब्लम होगा तो छूट जाता था. There are heterozygosity, homozygosity problem, there is imprinting disorder, there are a lot of things which we can speak, but that cannot be caught by array CGH, nowadays SNP. Now what we have this machine nowadays with sequencing and all, we are trying to do a low pass sequencing multiple times so that we can catch with the sequencer also the small missing part in the whole genome. If it is carrying an important gene, then it is a problem. Now, when you go with the whole exome and clinical exome, these all come from the pediatric population. But the problem with prenatal diagnosis is if you diagnose something, you don't know whether it is going to express whether the baby takes birth or not. So, don't go for too big test, too much test. You might have some problems which you never expected. And if you see the family is okay. Then from where this has come? So we have to be very careful as a prenatal diagnostic person. But in pediatric population, you see the phenotype. आपको बच्चा दिखता है कि उसको प्रॉब्लम है. ये हमको फीटस कहाँ दिखता है? हमको अल्ट्रासाउंड में दिखता है. वो यदि देख लिया हमने with a very good eyes and very good machine, very good expert, then only we can go for that test. Otherwise, try to restrict, be specific, see that what you want to see. Otherwise, sometimes a lot of variation of unknown significance came and they carry, this happens with me. I think Vivek have the same thought with me, that they carry with this report, they cannot express what is this. I think we will discuss this thing when we get time. Thank you very much.
Hello, good morning, all of you. And I'm very honored to be here, because this is the stage where I got the basics of fetal medicine in the FetusCon. I used to come in this FetusCon since long. In 2016, I first attended this FetusCon, and where I found that there is some specialty is there which is called fetal medicine, and I inspired by that very much. Then I left my 10 year of obstetrics practice and went for the fellowship in 2019, and I am in this field because of D'Pankar sir, because he motivated me very much. So in next 10-15 minutes we will discuss what is a soft marker in fetal ultrasound, list of ultrasound markers, and why and how is it significant, and importance of follow-up. So when we do fetal ultrasound, so some abnormality we could found, like major congenital abnormalities, some minor congenital abnormalities or soft marker we can detect, and we can detect some normal anatomical variant or transient finding. So some soft markers are the marker for chromosomal abnormalities. So as D'Pankar sir said, that it is very easy to diagnose Down syndrome by the neonatologist, by the seeing the features. But it is not so easy for us, for fetal medicine or imaging specialist. We have to do maternal screening, ultrasound, invasive testing. Then we can say that fetus is affected by some chromosomal abnormality or Down syndrome. So the soft markers are anatomical variant, and remember that these are not malformation, were originally introduced to prenatal ultrasound to improve the detection of trisomy 21. And these soft markers can be found in normal fetuses also, in about 15% of normal or euploid fetuses. So this is the list of soft markers for Down syndrome or trisomy 21, that is lateral ventriculomegaly, increased nuchal fold thickness, absent or hypoplastic nasal bone, EIF, echogenic intracardiac focus, aberrant right subclavian artery, echogenic wobble, renal pelvic test, short femur or short humerus. So, if we find 2 or more markers in a fetus, then invasive testing is recommended. There are 2 more markers like choroid plexus cyst and single umbilical artery, which we encounter in day-to-day practice, but these are not the marker for trisomy 21. So the first marker is lateral ventriculomegaly. So the cutoff of lateral ventriculomegaly is 10 mm or more in from the second trimester till third trimester. So the ventricles are measured at the level of atria in transventricular plane, and calipers should be placed in right position on to on. It can be bilateral or unilateral. The milder form, 10 to 12 mm, is the marker for trisomy 21. Moderate or severe, if it's there, it is more than 13, 14 or 15, so that could be due to some pathological problem. So the mild ventriculomegaly could be due to chromosomal abnormalities, genetic disorder or fetal infection like torch infection. So in such cases we have to do invasive testing to rule out the chromosomal abnormality as well as infection in the fetus. If it is isolated, then we have to do follow-up because it can be pointer or it can be due to some evolving anomalies. If it is isolated, truly isolated, means there is no chromosomal abnormality, no infection, and no any brain anomaly, then neurodevelopmental delay, risk of neurodevelopmental delay is very less. The second is nuchal fold thickness. It is the redentant skin at the back of fetal neck. The cutoff is 6 mm or more than 6. It is taken in transcerebellar plane with the angle of insulation of 30 degree, and it measured from the outer edge of the occipital bone to the skin of back or neck. It is strongest marker in the second trimester. So if it is isolated, even isolated, the further assessment to rule out the chromosomal abnormalities and other fetal structural abnormality should be done. Absent or hypoplastic nasal bone has a strong association with the Down syndrome, some microdeletion, duplication, and copy number variations. Absent or hypoplastic, both are equally associated with the Down syndrome, and ethnic variation is there. So to define the hypoplastic nasal bone, always we have to use the Indian nomogram. It can be unilateral or bilateral. Delayed ossification could happen, but it does not decrease the risk of trisomy 21. So it is taken in profile view in mid-sagittal plane, and angle of insulation should be around 45 to 135 degree. And definitely, if it is there in isolation also, further evaluation for the fetal structural abnormality as well as the chromosomal abnormality should be done. The echogenic intracardiac focus, we find very frequently in day-to-day practice. It is a small bright echoic focus within the fetal heart in the 4-chamber view. And it is most commonly found in the left ventricle, but it could be in the right ventricle or both ventricle also. And 90% disappear in the 3rd trimester or postnatally. And if it is isolated or the finding is isolated, no other structural abnormality is there, then definitely there is no aneuploidy risk. So further evaluation is not recommended or further testing is not recommended in echogenic intracardiac focus. The next is aberrant right subclavian artery or ARSA. It is most common aortic arch anomaly due to developmental delay. Normally we can see there is only 3 branches arises from the arch of aorta. The first one is brachiocephalic, which further divided in the right subclavian artery and internal carotid, right internal carotid artery, then the left internal carotid artery and left subclavian artery. But in this case, the internal carotid artery and aberrant right subclavian artery both are originated from the different places. And the aberrant right subclavian artery or ARSA arises from as a fourth branch from the arch of aorta, and it goes behind from the trachea and esophagus to the right side of the fetus. So it is found 0.5 to 1.3% in normal population, and it is associated with trisomy 21 and some congenital heart disease like chronotruncal anomalies. Isolated association is also found with the trisomy 21 as well as the 22q microdeletion. So if it is in isolation, then definitely we have to do further evaluation like fetal echo to rule out the structural abnormality. And some initially, means previously the amniocentesis is recommended in this, but some authors or some people are recommending that amniocentesis or chromosomal evaluation is not needed in isolated cases. Even I have did so many cases or amniocentesis done in ARSA, but I never found any trisomy 21 in isolated ARSA. So this is the ultrasound picture of ARSA, where we can see the aberrant right subclavian artery going behind the trachea towards the right side of the fetus. Echogenic focus, echogenic vowel, we call echogenic vowel when the vowel appear as echogenic as surrounding bone. It can be diffuse or focal. It is found in about 0.5 to 1.8% in the normal fetuses. In aneuploid fetus or Down syndrome fetus, the bowel movement is decreased and water absorption is increased. So the result, the dehydration of meconium is there, and then the bowel appear echogenic. So it could be associated with bowel loop dilatation, trisomy 21, 18, 13, and monosomy X also. The non-chromosomal associations are also there with bowel, in the form of bowel atresia, congenital infection, genetic disorder, cystic fibrosis, and fetal growth restriction. So if it is isolated, then definitely we have to need follow-up to see the growth of the fetus. The renal pelvic-tasis, we call when the dilatation of renal pelvis only is there, no calyceal dilatation, and we take the AP diameter. The second trimester criteria is 4 to 7 mm, and third trimester criteria is 7 to 9 mm. The aneuploidy is associated with the mild pelvic-tasis. But if it is isolated, there is very low risk of aneuploidy. But some non-chromosomal concern like the pelvic ureterojunction obstruction or vesico-ureteric reflex can be there, so we have to follow for that. And mild pelvic tasis in the third trimester, if it is present, then postnatal KUB ultrasound is recommended. So these are the pictures of mild pelvic tasis. We take the axial section, and spine should be either at the 12 o'clock or 6 o'clock position, and we take the measurement of the pelvis. Short femur or humerus, so it is also the marker for trisomy 21, but the bones are normal in shape and mineralization in these cases, and they can found, short long bone can be found in 5% of the normal fetuses. Some non-chromosomal association like the skeletal dysplasia, fetal growth restriction, and constitutional smallness can be there. So serial follow-up should be done in isolated cases to rule out the skeletal dysplasia or fetal growth restriction. Next is choroid plexus cyst. It is commonly found, and it is 1 to 2% of the pregnancy we encounter in day-to-day practice. It is because of CSF is rapid, choroid plexus is rapidly growing tissue. So some CSF is trapped in that. So it look like cyst. So usually it regresses in third trimester, and it can be single, multiple, unilateral, or bilateral. But these cysts are not associated with the trisomy 21. These can be associated with trisomy 18, but CP cyst plus structural abnormality is there, then the incidence of trisomy 18 is about 37%. So in trisomy 18, there will be some structural heart defect, clenched hands, talipus deformity of feet, or fetal growth restriction, or polyhydramnios can be there. So if this CP cysts are isolated, then the normal neurodevelopmental outcome we expect. And almost all the CP cysts disappear by the 26 to 28 weeks. Even there is no need of follow-up. The single umbilical artery is associated with 5% of the congenital abnormalities and about 10% of the fetal growth restriction. And some other associated abnormalities can also be there. So if the single umbilical artery is isolated, we have to do serial follow-up of ultrasound by the ultrasound for the fetal growth, and excellent postnatal outcome is there in isolated single umbilical artery. So we find some soft marker. So what we should do next? We have to do detailed anatomical survey plus fetal echocardiogram. And we have to see that the marker is isolated or some other marker is there. And what was the result of previous screening test? What we done in first trimester? So this is the list of marker for trisomy 21 as well as their likelihood ratio. So in this, the highest likelihood ratio is of absent or hypoplastic nasal bone. If it is isolated, then 6.58 is isolated likelihood ratio. Means if it is in isolation, there is chances of 6 times to 7 times higher of being Down syndrome in this and that fetus. Then URSA, ventriculomegaly, and nuchal fold thickness. So these 4 markers have the higher likelihood ratio. So if these 4 markers, even if they are present in isolation, then amniocentesis should be done and further evaluation should be done. Other markers do not increase the risk of trisomy 21 if they are isolated. So when the screening is positive for trisomy 21, or we find the major marker in the ultrasound, or NIPT or cell-free-DNA is positive, then we have to go for the amniocentesis. And if the chromosomes are normal, soft markers is there and chromosome is normal. So is that enough? So it is not enough, because soft marker can be pointer for the anomaly or evolving anomaly. It is not just about the chromosome. So we have divided in soft markers in 2 groups. There are soft markers which are non-concerned, that is EIF, CP cyst, and single umbilical artery, and finding of concern where we need to do further follow-up and further evaluation: ventriculomegaly, URSA, echogenic vowel, pelvic testis, or short long bone. So any unusual or some significant soft marker is there, then it need follow-up. So the soft markers can be due to chromosomal aneuploidy or due to non-chromosomal abnormalities. So if soft marker is there, beyond the Down syndrome, we have to see for the evolving anomalies like structural abnormalities and growth abnormalities. And very small subset of genetic disorder can also be associated with soft markers. So we do proper, appropriate prenatal counseling, and we expect the postnatal outcome. So in between, we do some evaluation like amniocentesis, counseling, as well as we talk to the neonatologist about our finding, and we bridge this gap, and we can means in the betterment of the fetus. So my take-home message is positive ultrasound marker for the aneuploidy need proper fetal anomaly scan plus echocardiogram. Any unusual or significant soft marker need follow-up, and the postnatal follow-up help us to understand the pathology and physiology better, and counseling plays a major role for decision making and postnatal follow-up. Thank you very much for patience listening.
If there are 2 soft markers, then we need the invasive testing. So if only EIF and mild pelvic test is present, then what to do? Because both have likelihood ratio of
low.
1. Yeah,
yes.
low.
Yes, low. So we have to see the previous screening test result.
Okay.
Okay. If suppose it is low risk, then definitely it would not increase the risk. So after genetic sonogram, we combine these two likelihood ratio of these two markers with the previous screening, and what result we found. Okay. If it is low risk, then definitely no need to do anything. Just follow up.
Thank you.
In ERSA or
Yeah, or otherwise also.
okay. So we adjust the risk of trisomy 21 in based of previous screening test. Like I have already said that, and the likelihood ratio of that particular marker, and then we readjust that risk. If it falls in high risk category, then definitely we do invasive testing, and we counsel the parents also. Although it is, when this marker was found, then it was given the likelihood ratio very high, and they recommend that we have to do invasive testing in isolated ERSA also. Okay.
So many a times patient comes directly at 4 months or 5 months when the screening tests were not available. So at that time, if a soft marker comes positive, which has a high likelihood ratio, should we suggest them for invasive testing, or we should just follow up?
Yes. If there are 3 or 4 markers which has very high likelihood ratio, then if they are in isolation, even your previous screening was low risk, then you can recommend the invasive testing in that case also. And if minor marker is there and no previous screening is done, then you have one prior risk of maternal age. So you can adjust that risk with maternal age, and you can act accordingly.
Alkesh, can we have concluding remarks from
Yes.
Nick?
Yeah, so I think he's brought out all the points very clearly. So if you have a soft marker, you assess the weightage of that soft marker in relation to that particular patient. Especially if she's undergone first trimester screening, there are software that help you recalculate the risk based on the soft markers that you see. And irrespective of 1 or 2 markers, the risk is still very low, then you don't need further invasive testing. But if you find multiple soft markers in a patient who has not been screened until that point, then even if they are minor markers, we'd probably offer an invasive testing.
Thank you.
Thank you, sir. Thank you for your excellent talk. And I know it is very clear now how to proceed further when we get these soft markers on our antenatal ultrasound. Thank you, sir.
Thank you.
Next, we have debate, moving towards a debate for NIPS versus first trimester screening as primary screening method in general population. For NIPT, non-invasive prenatal testing, Dr. Alkesh Soni. And for first trimester screening, we have Dr. Ashita. Moderator being Dr. Vivek Asthani and Dr. D'Pankar, sir. So I welcome for the debate.
Okay, thank you, sir. So before proceeding NIPT, we need to know some facts. So that every single woman who is pregnant is having some risk of chromosomal abnormality in her fetus. So out of 300, the one woman have the chromosomal abnormalities. About 95% are the common trisomies, like trisomy 18, 13, and 21. And out of these, the 75% are trisomy 21. And 90% of the trisomy 21 are born in the young mothers. So to detect the trisomy 21 or Down syndrome, we have definitive test, amniocentesis, and CVS. So these are diagnostic tests. But these tests have some inherent abortion of risk of abortion. They are costlier tests, as well as the unavailability of the experts. So screening is essential. So by the screening, we categorize the pregnant women in 2 groups, high risk and low risk. So those who fall in the high risk, we go for the invasive testing like amniocentesis or CVS, and those are at low risk, we do not offer any invasive testing. So the concept of the screening is to reduce invasive testing. So this is the news published in Times of India in 2017, where a couple alleged doctor and hospital because their baby was born with Down syndrome and congenital heart disease. The mother was triple marker was done, but it failed to detect the Down syndrome. So the question that the mother arises, why were these tests conducted if they failed to detect the anomaly? So we have to choose our test very carefully. Whose detection rate should be high, means number of screen positive out of affected. If there is 100 affected fetuses and if your test is detect 95% of those, then your detection rate will be 95%. So it should be high. False positive rate should be low, means screen positive is there but baby is normal. So if it is high, then unnecessary invasive we have to do. And positive predictive value should be high, means percentage of affected fetuses out of screen positive. Means if there is 100 fetuses which comes screen positive and there is 2 positive is 95, then your positive predictive value will be 95%. There are so many methods of screening which we do nowadays, like maternal age, but we do not consider maternal age as a screening in isolation, but it is important because it gives us a priority risk. So we have serum screening, ultrasound screening, combination of both ultrasound and serum screening, and NIPT. So this is a SOC guideline and recent guideline published in 2021, where we can compare the common screening which we are doing nowadays. So combined screening, which is maternal age plus gestational age, fetal NT, and dual marker test. This test has detection rate of 92% with the false positive rate is 4.6%. If we combine some other markers like nasal bone, ductus venosus, tricuspid regurgitation, then detection rate increases from 93 to 96% with the false positive rate 2.6%. If we do cell-free fetal DNA or NIPT with NT scan, then the detection rate is 100% with 0.1% of the false positive rate. And when we incorporate cell-free fetal DNA as a contingent screening, then the detection rate is 98% and false positive rate is 0.7%. So according to this table, we can say that cell-free fetal DNA or NIPT has the higher detection rate and low false positive rate. So what is NIPT? Basically, NIPT is quantitative assessment of cell-free fetal DNA in the maternal circulation. So the maternal circulation has both the fetal as well as maternal cell-free DNA. So we take blood from the mother and multiply the DNA, entire DNA, then identify the chromosome and align them, then stack them and arrange them, and check for the over-representation. If there is over-representation of trisomy 21, then we can say that this particular pregnancy is high risk for trisomy 21. So this is history. Basically, there is, in 1959, the author found that the intact fetal cells are present in the maternal plasma. Then the main change came in 1997 when Dennis Lowe et al. Found that the detection of cell-free fetal DNA in the maternal plasma and the new era of non-invasive prenatal testing is open. So it is integrated in clinical practice and represents the standard in developed countries today from the 1997. So fetal cell-free DNA, fetal DNA comes from the placenta and can be detected from the first trimester, 10 weeks onward, and it rapidly cleared from the maternal circulation after delivery. So that is very specific for that pregnancy only. So the maternal blood is therefore a reliable material for prenatal fetal DNA based testing. So it is done by the maternal blood, and it can be done any time after 10 weeks. And it can be done for the common trisomies as well as for sex chromosomal aneuploidies. We can detect by fetal RH by the NIPT. Microdeletions, microduplications, single gene disorder, and rare autosomal trisomies can also be detected by trisomy 21. So in this table, we can also see the sensitivity and specificity both are near to 98 or 99% for the all problems or all chromosomal abnormalities. For the trisomy 21, it is 99.4 sensitivity, and specificity is close to 100. So in this paper, the author did the cell-free fetal DNA as well as the standard screening in some women, and around 18,955 women were enrolled for this, and they found 15,841 are eligible for the study, and they concluded that routine prenatal screening population, the cell-free fetal DNA testing for trisomy 21 had higher sensitivity, a lower false positive rate, and higher positive predictive value than did the standard screening. So they did cell-free fetal DNA as well as standard screening, and 15,841 women, and they in the group standard screening, they found 884 positive for the screening test, and out of 884, 30 had trisomy 21, and 854 did not have trisomy 21. And in negative, those women were negative for the test. 8 had trisomy 21. In cell-free fetal DNA, they found 47 were high risk for trisomy 21, and out of 47, 38 had trisomy 21, and 9 did not have trisomy 21. But in negative patient or very low risk NIPT, they do not found any trisomy 21. So in terms of sensitivity, specificity, positive predictive value, the NIPT is better than the trisomy, for the trisomy 21 than standard screening. And for the trisomy 18 and 13 also, the sensitivity and specificity is remarkably high in the cell-free fetal DNA than standard screening. So as a screening test, it is most effective screening method for trisomy 21, has higher sensitivity and specificity than traditional screening. Detection rate is around 99.5 to 99.7%. The false positive rate is less than 0.1%. It is highly effective in high-risk population. It significantly reduced the number of invasive procedure, and risk assessment is independent of maternal age. So in twin pregnancy, the biochemical screening is complicated, and it has low detection rate than the singleton, but it can be offered. So Nicolaides and group says that the performance of cell-free fetal DNA testing for trisomy 21 in twin pregnancy is similar to that of reported in singleton pregnancy, and is superior to that of the first trimester combined test or second trimester biochemical testing. So NIPT in twin pregnancy give us the risk per pregnancy, not per fetus. High risk result require confirmation. We can tell that which twin is affected, and low risk has very high negative predictive value. Require slightly higher fetal fraction than the singleton pregnancy, but high order pregnancy still we cannot test. So if we are using SNP based NIPT, then we can separate both the fetus's DNA also. So SNP is a DNA sequence which variation occurring in a single nucleotide in the genome change, which is a part of natural variation in population. So it uses single nucleotide to change the differentiate maternal and fetal genome. So in the upper part, we can separate, in the upper part, this is monochorionic pregnancy. So in which we separate the maternal and the fetal DNA. And in dichorionic pregnancy, we can separate the mother as well as both the fetuses. Yes, sir. 2 minutes. Yes. So ACMG strongly recommend the NIPS over the traditional screening method for all pregnant patients with singleton or twin gestation for trisomy 21, 18, 13, and for the sex chromosomal aneuploidy also. We can also detect certain microdeletions and single gene disorder by the NIPT. So my conclusion is NIPT is non-invasive and safe, highly accurate for the common fetal aneuploidies, has low false positive rate, and it reduces the number of invasive procedure, which is our goal, and high negative predictive value. Risk assessment is independent of maternal age. So from 10 weeks of pregnancy for all single and twin pregnancies, including IVF, egg donor or surrogate pregnancy, we can offer NIPT. And it can be used for the rare autosomal trisomies, microdeletions and single gene disorder. Thank you very much.